Hello, everybody. It's Connor with IBBF here. It's wonderful to see you all. Welcome to our webinar. We are honored to have Dr. Rajesh Tampi as our guest speaker. He brings an impressive background and extensive expertise to this important discussion. He is professor, tenured, and chairman of the Department of Psychiatry and the inaugural Bahidi Family Endowed Chair in Psychiatry at Creighton University School of Medicine and the Catholic Health Initiative Health Behavioral Services in Omaha, Nebraska. He is also professor adjunct of psychiatry at Yale School of Medicine in New Haven, Connecticut. Dr. Tampi is the inaugural historian of the American Association of Geriatric Psychiatry, AAGP. He has also won numerous awards throughout his impressive career, including Clinician of the Year and Educator of the Year. We will include this great discussion with a short Q&A session, so please have your questions ready to type into the chat at the end of his presentation. And without further delay, I'll turn it over to Dr. Tampi. Go ahead, Doctor.
Hello, thank you, Connor. I'm going to share my screen. Can all of you see the screen? Connor, is it visible?
Yeah, you're good.
Thank you very much. So thank you, Connor, for that wonderful introduction, and welcome to all of you to this webinar. We are going to talk about evaluation and management of individuals with older age bipolar disorder. And I'm going to give you an overall view of this as a geriatric psychiatrist, and I'll be happy to answer as many questions as possible. Also, Connor will have a copy of my presentation, and he can share that with you at a later time. So I have no conflicts to disclose for this particular presentation. The objectives are very straightforward. I'm going to talk a little bit about the epidemiology of individuals with older age bipolar disorder. I'm going to talk about the assessment, and now, of course, the evidence-based treatment for individuals with older age bipolar disorder. So I just wanted to give an overview of bipolar disorder as I know it, so that we are on the same page when we have our Q&A session. So for me, the bipolar disorder is a chronic condition that is that presents with recurrent or cyclical episodes of, on the one hand, mania or hypomania, and depression on the other hand. There are two basic types of bipolar disorder, which is bipolar type 1 and bipolar type 2. So bipolar type 1 means any individual who has a manic episode at any time during their life meets the criteria for a bipolar 1 disorder. They may have recurrent episodes of mania, hypomania, or depression at a later date. Whereas bipolar 2 disorder, these individuals have hypomanic episodes, so they should never meet the criteria for a manic episode in the past. So these individuals have hypomanic episodes with recurrent depressive episodes that may present before or after the hypomanic episode. A little bit of statistics on the bipolar disorder. As you can see, the yearly prevalence of bipolar disorder is about 1.5%. It is almost similar between men and women and slightly more common in men. This is bipolar 1 disorder. It occurs usually in the early 20s. For the mean age of onset in the United States is 22 years, slightly older for men than women. What we also know with bipolar 1 disorder, that more than 90% of these individuals will have another mood episode. 60% of the manic episodes occur immediately before a major depressive episode. That's why it used to be called as manic depression. Whereas bipolar 2 disorder, the prevalence is slightly lower at about 0.8%. Instead of 90%, 50% experience a new episode within 1 year of the first episode. A very, very important thing to remember when we treat patients with bipolar disorder is suicidality. The risk of suicide in individuals with bipolar disorder is significantly higher. That is 20 to 30 times higher than in the general population. So whenever I see patients with bipolar disorder, whether they are younger or older, we always do a suicide assessment at every visit. The approximately 5 to 6% of individuals with bipolar disorder die by suicide, which is significantly higher, like I said, than for the general population. The risk for bipolar disorder in first-degree relatives is about 5 to 10%, which is about 5 to 10 times higher than in the general population. So it is a heritable illness, it is a cyclical illness, and the risk for suicide in bipolar disorder is very, very high, these individuals compared to the general population. When we talk about bipolar disorder, we also have to talk about comorbidities. That means these are other psychiatric disorders that happen along with an individual with bipolar disorder. So it is very rare in clinics to see patients with bipolar disorder who just present with that illness. They often present with other comorbid conditions. The common comorbid conditions seen in bipolar disorder and bipolar 1, it is anxiety, alcohol use disorder, and intermittent explosive disorder. Whereas in bipolar 2, it is anxiety, substance use disorder, and binge eating disorder. And when we come to the older age bipolar disorder, you will see some similarities between younger age and older age bipolar disorder. Differential diagnosis. So when we see a patient with bipolar disorder, we have to get a good history and we have to get a good differential diagnosis of what we are seeing. Like I said, many of these individuals will present with comorbid conditions. So you need to rule out whether this is a primary bipolar disorder or this is a primary depressive disorder, primary anxiety disorder, and a good history including information from collateral sources that includes family members, caregivers, friends, other providers. We usually do a good history to get the information so that we can differentiate bipolar 1 from bipolar 2. We can also then differentiate it from other psychiatric disorders, which may be the comorbid condition. So we need to do a good differential diagnosis because when you treat bipolar patients, you're not only treating the bipolar disorder, you also have to treat comorbid conditions. So what does older age bipolar disorder means? According to the International Society for Bipolar Disorders Task Force, older age bipolar disorder means the occurrence of bipolar disorder after the age of 50 years. What we know is 25% of all bipolar disorder cases occur after the age of 60 years, and over 10% occur after the age of 70 years. So as you get older, the risk gets less, but it is not completely gone. So older individuals, when I say older, means people who are in their 60s and 70s can also have their first bipolar disorder episode at that time. What is the prevalence? So if you contrast to a couple of slides ago, bipolar disorder, older age bipolar disorder occurs less frequently. So between the point prevalence is between 0.1 and 0.5%. Lifetime prevalence is between 0.5 and 1%. What we know is that 10% to 25% of all older adults who are diagnosed with a mood disorder present with bipolar disorder. The rest of them are diagnosed with either a depressive episode or dysthymia. Now, where do we see these individuals? You can see patients with bipolar, older age bipolar disorder anywhere, but more commonly, they usually are seen in the emergency rooms or in residential psychiatric programs. Less commonly, they are seen in chronic institutions like nursing homes. And what we also know is that 70% of all cases of older age bipolar disorder are women. If you remember from the third slide, in bipolar disorder in younger adults or early onset bipolar disorder, it is almost a 1-to-1 male to female ratio, whereas older age bipolar disorder, 70% of the cases are women. Usually in younger, early onset bipolar disorder, manic episodes or hypomanic episodes may happen earlier, whereas in older age bipolar disorder, depression is the usual common presenting symptom. Unless you take a detailed history, sometimes you might miss the fact that after the depressive episodes, the patient had either a hypomanic or a manic episode. So a good history is very, very important as a geriatric psychiatrist to rule out and diagnose bipolar disorder. What we also know is that once the depressive episode happens, they are usually recurrent and more severe. Periods between each episode of the bipolar disorder seems to be longer when compared to early onset bipolar disorder. Another difference is that people with older age bipolar disorder have less family history of a mood disorder, which includes both depression and bipolar disorder, when compared to early onset bipolar disorder. However, older age bipolar disorder individuals have more stressful life events when compared to age match controls. So stressful life events can trigger a hypomanic or manic episode or a depressive episode followed by a hypomanic or a manic episode. What we also know is that many of these individuals may have comorbid medical conditions. They may have comorbid cerebrovascular conditions. That means they may have stroke-like symptoms, blood vessel changes within the brain, and usually right-sided cerebral hemisphere, right-sided brain lesions can cause manic symptoms, whereas left-sided brain lesions can actually cause more depressive episodes. Like I said before, they have more comorbid medical conditions, especially cerebrovascular, cardiovascular, and metabolic disorders. So when we evaluate these patients in our clinic, we always do a very thorough medical history. We look at their medications. We make sure that we are not giving medications that can worsen the individual's medical conditions. And what we know is that comorbidities are associated with worse prognosis and worse outcome and higher rates of suicide. So again, every assessment we do of an older age bipolar disorder will include a good history. We will do a good medical evaluation. We will screen for suicidal risk because the suicide risk is significantly higher than in the general population. What about psychiatric comorbidity? So I want you to think back to the early onset bipolar disorder. Psychiatric comorbidities are more common in individuals with older age bipolar disorder compared to age-matched controls. However, they're less common when compared to early onset bipolar disorder. What are the comorbid conditions, psychiatric conditions that we see in older age bipolar disorder? Very similar to the younger age bipolar disorder, alcohol use disorder, dysthymia, which is a chronic depressive state, anxiety disorder, including generalized anxiety disorder, and panic disorder. So substance use disorders, alcohol use disorder, dysthymia or chronic depressive episodes, and anxiety disorders are more common in older age bipolar disorder when compared to age-matched controls. What else do we know when compared to age-matched controls? Men with older age bipolar disorder have greater prevalence of alcoholism, whereas women have more anxiety symptoms, especially the panic disorder. Psychotic symptoms, which includes delusions, which are false fixed beliefs, and hallucinations, they're similar to early onset bipolar disorder. Risk for suicide among older age bipolar disorder is lower than in early onset bipolar disorder, but it is significantly higher than when you compare to age-matched controls. So everything is much worse than age-matched controls, but psychiatric comorbidities and suicide risk are slightly lower than in early onset bipolar disorder. What is it? Another difference. In the older age bipolar disorder patients have more cognitive impairment. That is, includes memory, attention, concentration, depth perception, and all of those are much worse than all age-matched controls and early onset bipolar disorder. What we also know is that individuals with more vascular risk, so individuals with high cholesterol, high sugar, hypertension, that means high blood pressure. These individuals are at greater risk for developing more comorbid conditions and more admissions to the hospital and worsening cognitive conditions. So comorbidities are bad in individuals with bipolar disorder, but unfortunately, many of these individuals that we see in our clinic tend to present with comorbid conditions. So as a geriatric psychiatrist, my responsibility is to do a good history, a good medical evaluation, make sure that we are screening for suicide and also treating not only the bipolar disorder, but also treating comorbidities and not to prescribe medications which can make the comorbid conditions worse, which includes medical comorbid conditions. So this is a very simple summary of the differences between early onset bipolar disorder versus older age bipolar disorder. As all of you by now know, older age bipolar disorder is individuals who develop bipolar disorder after the age of 50, whereas early onset bipolar disorder is any individual who develops it before the age of 50. Family history, less likely in older age bipolar disorder, more likely in early onset bipolar disorder. Often depression is a presenting symptom in older age bipolar disorder. In early onset bipolar disorder, mania or hypomania may be the more common symptom. That's why we used to call it manic depression. Manic symptoms, less likely in older age bipolar disorder, more common in early onset bipolar disorder. Latency, that means time between the first and the second episode, is significantly higher in older age bipolar disorder, whereas it's shorter in early onset bipolar disorder. Cerebrovascular disease, that is the brain vascular disease, brain blood vessel changes, more likely in older age bipolar disorder, less likely in early onset bipolar disorder. Medical comorbid conditions are more likely in older age bipolar disorder, less likely in early onset bipolar disorder. Psychiatric comorbidities, less likely in older age bipolar disorder, more likely in early onset bipolar disorder, but psychiatric comorbidities are more than the general population in older age bipolar disorder. Cognitive dysfunction is more common in older age bipolar disorder when compared to early onset bipolar disorder. Health service utilization, that means use of the emergency room, use of outpatient clinics, use of inpatient units are much more common in older age bipolar disorder when compared to early onset bipolar disorder. So how do you evaluate a patient who comes in with older age bipolar disorder? Like I said before, history is a very, very important aspect. You're not only getting history from the patient who's sitting in front of you, we often try to get information from other collateral sources with the patient's explicit permission. So patient's family members, patient's physicians, any other source that can help us make the diagnosis or differentiate whether this really is an older age bipolar disorder. We do a good mental status examination. We do formal cognitive testing. So we screen for memory problems. We screen for attentional problems because, as you saw earlier, older age bipolar disorder patients often present with significantly more cognitive issues. We may also get neuropsychological testing from a psychologist if it is not clear whether this individual has an older age bipolar disorder or the patient has other comorbid conditions and they are having an underlying dementing illness that is presenting as mood instability. So in those situations, we actually get neuropsychological testing. Often I have to do a physical examination, including neurological examination, because as you already saw, these individuals can present with multiple medical, psychiatric, and even neurological co-occurring or comorbid conditions. We also do appropriate lab work, which includes blood testing. We may do a urine drug screen. We may need MRI scans of the brain to rule out if the individual has an underlying medical condition that is resulting in what appears to be hypomanic or manic or depressive symptoms. Once we do all of that workup, only then would we diagnose somebody with a bipolar disorder and then discuss treatment with the patient and the patient's family members if the patient wants them to be involved. So again, a good history, good lab work, good physical examination, rating scales, maybe getting some additional testing like imaging studies of the brain and neuropsychological testing, and then making a diagnosis of bipolar disorder. So it's a process rather than an event. Are there screening tools that we do? There are screening tools that are available, which are not specific to older age bipolar disorder, but you can do this on any individual with bipolar disorder. We do the MDQ or the Mood Disorder Questionnaire. It's a screening tool. History is and the screening tool together will help us come to a diagnosis of whether the individual has bipolar disorder or not. And if it's a bipolar disorder, is it a type 1 and type 2 bipolar disorder, and what other comorbid psychiatric disorder the patient is having. Treatments for bipolar disorder. Non-pharmacological treatment, that means therapy-based treatments, have been shown to be beneficial in older age bipolar disorder. And two of the treatments that I could find evidence to when I wrote the paper, we found that medication adherence skill training and manual-based medical care model helped improve medication management and improved treatment of medical comorbidities in individuals with older age bipolar disorder. But the main treatment is pharmacological or medication-based. Among these, we're going to talk about lithium. We're going to talk about anticonvulsant mood stabilizers like lamotrigine, divalproic sodium, or Depakote. We're going to talk about antipsychotic medications. We're going to talk a little bit about antidepressants. We're going to talk a little bit about benzodiazepines, and of course, electroconvulsive therapy. And again, electroconvulsive therapy is not equally available in all the states in the United States. So it depends upon what geographic location you are available. But in the 3 states that I have practiced, that includes Connecticut, Ohio, and here, we do electroconvulsive therapy for certain situations in bipolar disorder, and I will show you those conditions that we use it for. So lithium is a prototypical drug. It has been available in the US for close to 55, 56 years. It is most beneficial for individuals who present with manic symptoms. It is also not very helpful in individuals who present with neurological comorbid conditions. So a patient who does not have significant neurological disorders, that is probably the better patient for using lithium. What we also know very clearly is that lithium does reduce the risk for suicide. So it is one of those indications that we use it for, and it may reduce cognitive decline. So there is emerging data that lithium can actually be neuroprotective and reduce a decline in memory and cognition. When we dose lithium, we dose it at lower doses than in younger patients. We use a quarter to half the adult dosing, and we try to do the lithium levels to be between 0.4 and 0.7. Remember, lithium can be toxic to your kidney, can cause significant adverse effects and even death if it is in high levels. We may have to do renal dialysis if the level goes high. So we try to keep the dosing of lithium between 0.4 and 0.7. And that's why the doctor will order lab tests immediately after you start the lithium at about 4 to 7 days. You do the lab work and then you continue monitoring lab work. You do the monitoring basically for adverse effects, not for efficacy, but there is some evidence that between 0.4 and 0.7 is where it is most efficacious. You're mainly looking for adverse effects, which include sedation, weight gain, walking difficulties, thyroid dysfunction, edema, which is swelling of your limbs, kidney dysfunction, and of course, if patients are taking higher doses of lithium, they may have some cognitive dulling. It really doesn't cause, it actually is protective against dementia, but some people they say that they have like a fog-like feeling in their head. So those are the side effects of lithium. We also have to be very careful when you co-prescribe lithium with certain blood pressure medications, including the diuretic medications like the thiazide or the loop diuretics, or when you're giving medications like Motrin or ibuprofen, which can cause lithium toxicity by increasing the reabsorption of lithium from the kidney. So you have to be careful when you prescribe medications to lithium to older patients, because many of these older individuals are already taking many of these medications. So you have to manage the lithium dosing with either the patient's primary care doctor, or sometimes you have to manage it with a nephrologist who's also treating the patient. What about the anticonvulsants? When I say anticonvulsants, these include medications like divalproic sodium, which is Depakote. So there is only one randomized control trial. And as you all know, randomized control trials are the gold standard for assessing efficacy of medications and tolerability of medications. And unfortunately, there is only one randomized control trial of anticonvulsants in older age bipolar disorder patients. These were individuals who were above the age of 60 and had bipolar 1 disorder. That means they had a manic episode at some time during the illness, and they may have had hypomanic, manic, or depressive episodes subsequently. They targeted lithium concentration slightly more than what you would see in the normal older adult patients. So they did between 0.8 and 0.99. And the divalproic sodium, or the sodium valproate concentration, was between 80 and 99. So very much like an adult dosing than a geriatric dosing. And if the patients did not respond adequately to these medications, they had a rescue medication, which was using risperidone, which is an atypical antipsychotic medication. As expected, the investigators did not find any significant difference in response rates between patients who were taking lithium versus the divalproic sodium. The attrition rates, that means the number of patients who dropped out, were also fairly similar at 3 weeks and at 9 weeks. There was no difference in sedation between the two groups, the patients who were taking lithium versus the divalproic sodium, but individuals with lithium did have a little more tremor. So based on this study, you can say lithium and divalproic sodium, or the sodium valproate group of drugs, very similar efficacy, other than the fact that patients in lithium on lithium may have somewhat more tremors than patients who are taking the divalproic sodium. This is not an randomized controlled trial. It's a retrospective review of a mixed age population. Mixed age means it includes slightly younger patients and older patients. This was mainly individuals who were 55 years and older. Again, they had bipolar 1 disorder. And what the investigators looked was comparing lamotrigine, which is Lamictal, with lithium versus placebo. What the investigators found was that lamotrigine is good for any intervention, any mood episode, and for a depressive episode when compared to placebo. So based on this data, when we use it usually for depressive episodes and not really for a manic episode. Whereas lithium was most beneficial in decreasing the manic, hypomanic, or mixed episodes when compared to placebo. So we don't use lithium for treating depressive episodes. We usually use it to treat the hypomanic, manic, or mixed episodes. Whereas lamotrigine, we use it more to treat the depressive episodes. Tolerability, lamotrigine is fairly well tolerated. Back pain and headaches were the more common side effects, but there was no rashes in the older age patients, let's say so. Lithium, of course, had slightly more side effects, including the things that we already looked at. There was some tremors, there was some difficulty with motor coordination, there was dry mouth, headache, infections were common. Amnesia, again, because of the clouding of the patients have this cloudy feeling. Dizziness, diarrhea, nausea, and vomiting were also side effects. Lamotrigine is also a medication which appears to have a favorable cognitive profile compared to lithium and other anticonvulsant mood stabilizers. So when patients are complaining of this sort of dulling feeling, we often switch from lithium to lamotrigine if the patient is having a depressive episode. Lamotrigine has not been found to be all that beneficial for manic episodes, so we don't use it to treat manic episodes. It's mainly treating depressive episodes where we use lamotrigine. What about antipsychotic medication? The FDA has approved multiple antipsychotic medications, which includes aripiprazole, Abilify, acinapine, cariprazine, olanzapine, quetiapine extended release, which is the XR version, risperidone, and ziprasidone. But for acute bipolar depression, the FDA has approved cariprazine, olanzapine, fluoxetine combination, which is a combination of two drugs, lumateperone, lorazepam, and quetiapine. Cariprazine, olanzapine, fluoxetine combination, and quetiapine are approved for monotherapy. That means you can use them alone without any other medications, whereas lumateperone and lorazepam are used either as monotherapy or as adjuncts to other medications. For example, it could be lithium, it could be lamotrigine, it could be divalproic sodium, so any of the other medications. So these are the antipsychotics that are available, and I'm going to show you a little bit of evidence for each of these medications. So for quetiapine, there is one post-hoc analysis from two monotherapy trials. The doses were fairly substantial, between 400 and 800 milligrams, so very much the adult dosing. These were individuals who were 55 years older and had bipolar disorder and were presenting with a manic episode. And quetiapine was very, very beneficial. And the benefits were sustained over 21 days, and the benefits started as early as four days. So if the patient has a manic episode quetiapine is a good medication to use, especially if you're on the inpatient and you can titrate it up quickly and use fairly adult dosing. Side effects, of course, any medication when you titrate up, side effects do happen. And in this study, the side effects that were more common were dry mouth, somnolence, postural hypertension. That means your blood pressure will drop, insomnia, weight gain, and dizziness. Very much what we would see in our outpatient clinic as well. So in the outpatient clinic, we usually do a slower titration of medications, and it's very rare that I have gone up to 800 milligrams. I don't even remember if I have any patient at that high a dose. What about asenapine, another atypical antipsychotic medication? No randomized controlled trial, but there is one prospective open label trial where asenapine was used in addition to other medications when there was inadequate dosing. And what the investigators found that overall symptoms for bipolar disorder were reduced, uh, manic symptoms were reduced, and depressive symptoms were reduced. And the mean dosing was about 11.2 milligrams. The maximum dose of asenapine is about 20 milligrams. So half the dose was adequate as a mean dose to help reduce the depressive symptoms, manic symptoms, and overall symptoms of the individual. Side effects, of course, were present, with GI symptoms, gastrointestinal symptoms being the most common, restlessness, tremors, cognitive difficulties, and sluggishness, all being equal, were present. So we do use epinephrine from time to time, and we often use it as an adjunct, not as a monotherapy for individuals with older age bipolar disorder. What about lurazidone? Lurazidone has two randomized controlled trials. This was again a mixed stage population. These were individuals who were older, over the age of 55, and who met the DSM-5 criteria for bipolar 1 disorder. So again, the individuals had manic episodes at some time during their lifetime, and then they presented with hypomanic and depressive episodes, and they were looking mainly at bipolar depression. The monotherapy study looked at fixed doses, flexible doses. That means between 20 and 60 was one group, and then 80 to 120 was another group, and they compared it with placebo. The adjunctive study, the lurazidone was used in combination at doses of 20 milligrams to 120 milligrams a day, either as combination to lithium or to divalproxodium. And the main outcome they were looking at was what is called the Montgomery-Åsberg Depression Rating Scale, or the MADRS total score. And what the what the investigators found was that the monotherapy study showed benefit for these individuals at week 6. And so it is a very good medication to treat bipolar depression. The adjunctive therapy did not show any additional benefits. So we often use it in older age bipolar disorder in our clinic as monotherapy for acute bipolar depression. The medication was very well tolerated and did not cause significant lab value changes. We're talking about changes in cholesterol, sugar. They did not cause significant weight gain. So we often use lorazepam to treat acute bipolar depression among older age bipolar patients in our clinic. What about antidepressants? The evidence is that antidepressants in early onset or younger onset bipolar patients don't do very much anything for these individuals. Very similar finding in older age patients. There is one retrospective cohort study which found that the antidepressants did not worsen mania or hypomania, but it was not very beneficial for depressive episodes. So we hardly ever use antidepressants to treat bipolar depression. We usually use medications like lorazepam, lamotrigine, and the other ones like quetiapine XR to treat bipolar depressive episodes. What about benzodiazepines? And as all of you may know, benzodiazepines are among the commonest medications prescribed. So there are two retrospective trials which have looked at the use of clonazepam in older age bipolar patients. And these two studies showed that benzodiazepines are not effective in older age bipolar patients when compared to individuals who have major depressive disorder. So we hardly ever use medications like clonazepam for our older age patients because the risk for falls the risk for cognitive decline, the risk for motor incoordination is so high, and our older age patients are taking so many other medications and have other medical comorbidities. So it is a huge risk for us to take. So in our clinic here, we hardly ever use these kind of medications. And if the patient comes to our clinic with these, our goal is to work with the patient on minimizing the use of these drugs. What about electroconvulsive therapy? And like I said before, electroconvulsive therapy is not equally available in all the states in the United States. So again, its use is varied, but we use it often to treat patients who have not responded to other medication treatments. We often use it to treat acute psychiatric emergencies among bipolar disorder patients. This include patients who have severe mania, which has not responded to any of the other medications. We often use it to treat patients who have bipolar disorder, who are actively suicidal or homicidal, patients who are catatonic, patients who have significant delusions or hallucinations, very agitated patients who have not been able to respond to any of the other treatments. ECT is very helpful. ECT is also very useful in medically unstable patients in whom other medication or medication classes cannot be used because of risk of side effects. ECT has been very helpful. Among all bipolar disorder patients, ECT has an effectiveness of 80%. With right unilateral and bilateral ECT having equal effectiveness, but bilateral ECT has a little more post-ictal recovery times. That means after the seizure, the recovery takes a little more time and slightly more memory impairments when compared to right unilateral ECT. So again, a life-saving treatment for many of our patients, but it is not available in all the states equally. So you need to be just cognizant of that fact. So based on all the evidence that we had collected, when I say we, it's me and my team have collected, we actually published this as an algorithm in one of our papers. So here is how we use these medications. So for manic episodes, we can use lithium. We usually use lithium also for maintenance treatment. We use it about quarter to half the adult doses. The levels, as I said before, is between 0.4 and 0.7. Despite all of this, lithium is not as well tolerated in older adults as in younger adults. Anticonvulsants are better for individuals with mixed episodes. That means they have a combination of hypomanic, manic, and depressive episodes. These individuals, they are also good for rapid cyclers. That means patients who are having 4 distinct episodes of either depression or hypomania or mania, in one year. They're also better for people who have more comorbid conditions. They're also fairly good for maintenance treatment, and we use a quarter to half the dose of the adults, but still tolerability is an issue. Atypical antipsychotics, mainly used for manic episodes and maintenance treatment, a quarter to half the adult dose, less well tolerated. And if the patient has comorbid dementia, the risk for stroke and death is higher. So very, very careful if the patient has a comorbid dementia diagnosis along with a bipolar diagnosis. For depressive episodes, lithium is not often used for treating acute depressive episodes. It may be okay for a maintenance treatment as before, quarter to half the dose, 0.4 to 0.7, less well tolerated. Anticonvulsant mood stabilizers, lamotrigine is the preferred drug for treating depressive episodes. For the atypical antipsychotic medications, they are indicated for acute bipolar depression, which includes lurasidone as monotherapy or as adjuncts to lithium or divalproex sodium, olanzapine fluoxetine in combination, or quetiapine as monotherapy. Again, using lower doses, quarter to half the adult doses. They're less well tolerated even in those lower doses. So again, it is a fine balancing act we have to do. They do tend to cause metabolic problems even in older adults. If the patient has comorbid dementia, you have to be careful because the risk of stroke and death is higher. Electroconvulsive therapy, like I said, we use it for emergency conditions and when all else has failed. Psychosocial treatments, therapy-based treatments are used as adjuncts to the medication management. And these are my references, and Connor will have I will have the slides available for you if you need it, and I'm happy to sort of answer any questions that you have regarding not only older age bipolar disorder, any topic in geriatric psychiatry. Thank you for listening.
What a wonderful presentation. We will now begin our Q&A session. Please type your questions into the chat.
So Connor, I see one question.
Yep, I'm about to read it.
Got it. Thank you.
Yes, just takes a little time.
Thank
Please
you.
comment on people who get a diagnosis of bipolar disorder later in life, and when looking back at their lives, they have clearly had a long time all their lives versus people who develop OABD after 50. Are they clinically considered the same thing? Is OABD treated any differently than late diagnosis BP or BD?
Yeah, thank you, Derek, for that wonderful question. And so again, this is why history is so important. We do get a lot of patients who come in with a diagnosis of major depressive disorder, and when we take a good history, we find that they have had hypomanic and manic episodes in the past, but they have been treated as a patient with individual with major depressive disorder. So again, OABD is for patients who actually have the hypomanic manic episodes after the age of 50 years. So the person that you're talking about who's had lifelong history, we would consider it as early onset bipolar disorder. And our treatment's significantly different. If you actually saw all the medications that we use, the treatments are very similar, but as the individual is growing older, they have more comorbid medical conditions and psychiatric conditions. So we often use the medications, but at a lower dose. That's the difference what to do. And we probably have slightly more closer follow-up. And for some patients who have cognitive issues or memory difficulties, we watch them even more carefully.
That was a wonderful response. The next question is, when during a depressive or manic episode is death by suicide most prevalent?
Thank you for asking that question, Chuck. You know, usually the risk for individuals with bipolar disorder is present all the time. So it is acutely present when the patient has an either acute depressive episode or an acute manic episode. And usually in the manic episode, patients have the higher suicide risk when the mania is starting to now convert into a depressive episode. So anytime patient is admitted to a hospital, and being discharged for a manic episode, that is a risk. Patient with depressive episode, their depressive episode is getting worse. They are starting to have suicidal ideation. That is a high risk. So for me, any patient with bipolar disorder, when I see them, I always do a suicide risk assessment because you are not sure as to how severe the depressive episodes are or the hypomanic episodes. Of course, the manic episodes, you can clearly tell when you see the patient. So the risk is there all the time, but during acute crisis, the risk actually gets worse.
Excellent. And the next question is, what medications can cause forgetfulness?
Well, Chuck, the answer is that medications can, if you're using higher doses of medications, they can make you more sedated. They can fragment your memory. Any medication can actually cause that. But preferentially in individuals who present with memory difficulties, who are not having dementia, we would use something like lamotrigine because it seems to have a lesser side effect of causing sedation and that kind of forgetfulness. But none of these medications, other than benzodiazepines, that means medications like clonazepam, lorazepam, oxazepam, temazepam, all of those, those can cause significant memory difficulties and dementia. So we don't use those medications. So with all the other medications, we try to use lower doses so that patients can tolerate it better. Again, we do a good history, we do a good physical examination, we do lab work, we do memory testing, and we follow the patient closely.
And the next question is, tell me about mixed anxiety depression and how it shows up in patients.
Yes, so it can present. So thank you, Syed, for that question. So it can present in patients differently. So for usually, if the patient presents with depression and anxiety, some people they may feel more irritable, they may feel more edgy, they may feel more angry. In some other patients, they may have that perplexed feeling. They may feel as if they are not able to control themselves. Some patients present with heightened suicidal risk. So again, it depends upon what the patient is presenting. When you see a patient, we should always, as a psychiatrist, we always do a good history. We try to get information from other sources who know the patient. We do a good physical examination. We do lab work. We do rating scales to find out whether the patient has a primary condition, what primary condition that is, and what secondary conditions. Because if you just go with a one diagnosis, you may miss a patient who's presenting with a bipolar disorder and a generalized anxiety disorder or panic disorder. So again, the presentation is very individual, but a good history should be able to clearly identify what is the primary condition and what are the other conditions.
And the next question is from Anthony, and it says, can you address HIV and bipolar disorder?
Yeah, thank you, Anthony. I mean, I think you are the person who asked the question first, so we apologize. So that is very, very important. Yes, patients with HIV can also have bipolar disorder, or patients with bipolar disorder can also have HIV. So the way we treat patients who have these two conditions is we do the same thing. We do a good history, we do a good physical examination, we do lab work, we co-manage the patient with their infectious disease doctor and their primary care doctor. We are just very cautious when using medications because some of the medications to treat bipolar disorder may interact with some of the HIV medications. So caution is what we do, and we do a very good what is called medication reconciliation, where we review the medications and we make sure that the patient has these medications optimized. Optimized means the patient has good efficacy and least side effects.
Wonderful. And the next question is from an anonymous attendee, and it says, I've heard that the term functional bipolar disorder. Can you please comment or clarify?
Thank you for that question. I have also heard that term. I really don't know what it means. I think what it means is individuals with bipolar disorder who are having these symptoms but are not clinically significant or clinically severe enough to come to a professional's attention, but they're managing. My recommendation to those individuals is I think you need to go see a provider so that they can screen for those, because even people who have mild depressive symptoms, mild anxiety symptoms, hypomanic symptoms, which seem that patients appears are doing well, these individuals later on can have bad outcomes, including worsening medical conditions, worsening psychiatric conditions. So even a subclinical symptom in any patient, it needs to be evaluated, not necessarily treated by medications. They may actually be treated with therapy. And so it is important for these individuals who have what is called the functional bipolar disorder or functional anxiety or functional depression should see their provider and see if they need to be receiving therapy and or medications.
That's an excellent response. The next question is from Mark. Is it possible that you can be diagnosed with bipolar type 1 in your early 60s, but back at your life, you may have had it much earlier in life?
Thank you, Mark, for that question. Like I had said earlier, absolutely. We do see a lot of patients who have had manic episodes in the past, and but they had forgotten about it, never reported, and they were being treated as a patient with major depression. So when we take a thorough history, we find that they've had manic episodes in the past. So we would treat them as an early onset bipolar disorder. Treatments are not all that different because majority of the studies have been done in mixed age population, and there is only one randomized controlled trial looking at placebo versus lithium versus divalproic sodium or Depakote. So the treatment way we do it is we look at the patient, do the evaluation, then we discuss appropriate treatments, and then we monitor them a little more closely because as you get older, you may have more medical and comorbid psychiatric conditions.
Wonderful. And our next question is from Rebecca. What do you notice as changed behaviors? What is the difference between EO and OA?
Yeah, thank you for asking that question, Rebecca. So early onset means these are individuals who have the first hypomanic or manic episodes, usually in their early 20s. Late onset is individuals who have these episodes after the age of 50. Is there a huge difference? Like I just was answering, the earlier question, many of these individuals may look very similar. The difference is that they have been treated, the early onset individuals may have forgotten about the manic episodes and they're being treated for a depressive episode, not realizing that they have had a manic episode in the past. Whereas individuals who are having the episodes of hypomania, mania in later onset, because it is all closer to when they're coming to see a doctor, they probably remember it. So treatments are very similar, except that as you're getting older, we use lower doses of medications to start with, but sometimes we may have to go to the normal adult dosing in patients who don't respond. So again, it is the presentation may not be all that different between these two individuals.
Excellent. And our next question is from an anonymous attendee. Interrupted speech patterns occur during a recent manic episode. Is that a common feature of mania?
That is not that common. If the patient is having speech pattern problems and they're getting older, I would recommend that they need to go see their primary care physician and probably see a neurologist because speech abnormality is not that common in individuals with bipolar disorder.
Well, everybody, I really appreciate all those thoughtful
So,
questions.
Connor, I think there is one question that Katie has asked. Did you see that?
I did see it, but we can't actually answer those types of questions.
Okay,
Yeah,
got it. Okay,
sorry.
thank you.
Yeah, okay. Well, I really appreciate everyone's questions. They were very thoughtful. This webinar will soon be available on our educational video section of our website, so stay tuned for that. A huge thanks to everyone who participated, and of course to our audience and Dr. Tampi for all that useful information. Dr. Tampi, would you like to close us with any thoughts?
No, I am. Thank you, everyone, for being here and patiently listening to what I had to say, and for all the wonderful questions. So, if you have, anyone who has a loved one with bipolar disorder, if you have bipolar disorder, my recommendation is to make sure that you follow up with your provider and discuss your treatment plan with them. And if there are any questions or concerns, you can always get a second opinion to doing that. So, I wish all of you good health and a wonderful afternoon. Thank you all for being here today.
All right, goodbye, everybody.
Thank you.